Okay, we're on the CTisus quiz, and hopefully I could share with you 10 cases. Let's get started. Patient has cough and abdominal fullness. There's some vascular lesions in the liver, and I'll tell you those are a combination of FNH and hemangiomas. We're not going to worry about them. But what about the cystic lesion pushing on the aorta and left kidney? What is that? It's water density. You can see it pushes on the aorta. If the patient had surgery, lymphoceal seroma would be possibilities, but the patient had no surgery. It's well-defined water density. Typical things you think about: lymphangioma. I guess you could consider an old hematoma, but that would be unlikely. It's so nice and homogeneous. Um, Neurogenic type tumor, again, can be low density and displaced vessels, so that's a possibility. But I think the best thought would be a lymphangioma. Now, this patient was interesting. They had lymphangioliomyomatosis, and although it looks like a lymphangioma on path, there are some muscle cells, and it's considered a lymphangioliomyoma, but for anybody else, it's a lymphangioma. And again, just some comments about that. Smooth muscle cells in addition to the lymphatics. So it's in lamb. Back pain. Couple studies. Here's a paratracheal mass and paraesophageal mass, low CT attenuation, and these large masses in the abdomen. Now you could say, could this be a lymphangioma? Looks a little bit like the last case, but it has septations, but lymphangiomas can have septations. But then how do you explain what's going on in the patient's chest? 6 weeks later, the mass in the neck is larger, the nodes in the abdomen are larger, they're cystic with septations. Look how it displaces the kidneys and the renal arteries. What gives you cystic nodes? Lymphangioma, cystic masses, but not in chest and abdomen. You could say Whipple's disease, but that's low density nodes, not to this extent. You could say TB gives you low density nodes and can be in chest and abdomen, but this is just too large. And when you see this appearance, you got to be thinking about a germ cell tumor, and this was a seminoma. So we've seen a number of cases where they present as anterior mediastinal masses or paratracheal masses, then have the large abdominal disease, cystic lesions, very nice testicular seminoma. Now, a couple of cases that are incredibly impossible: left upper quadrant pain, mass pushing on the patient's stomach. This is a large splenic mass. Now, it could be a hamartoma, though I like hamartomas to be more vascular. It's not going to be a lymphangioma. It's not low density enough. It's not a hemangioma. Could it be a sarcoma? That's a possibility. But there's no way I can call this a benign leave-alone lesion. You see the mass effect on the stomach, and it is kind of low density, but still, I can't really exclude a tumor, including lymphoma, but there were no nodes anywhere. And this was an inflammatory pseudotumor. And I just show you this case. It's a good example of a large splenic lesion, and it's impossible to diagnose. This article makes the point: it's hypodense, it's rare, but the only way you could diagnose it is with pathology. That's it. Another vague abdominal pain. I like this case: multiple vascular lesions in the spleen and arterial phase imaging. You can see them very nicely on the coronal. And then as you go to venous, you can see the lesions are still present. I'm showing you two of them on the coronal, but they're less bright. And when you go to the excretory phase, this was a kidney study, by the way, which explains the multiple phases, and the lesions are gone. Incidental hypervascular splenic lesions, very bright, washes out further. That's going to be splenic hemangiomas. Really nice example. 40-ish-year-old female, cystic lesion or cystic and solid, well-defined head of pancreas. No dilated common duct, no dilated pancreatic duct. What are you thinking of? Well, you're not thinking about a cancer. It's not a pseudocyst. Serous-cystadenoma, possibly, but it's almost too solid. You can get solid serous-cystadenomas, but they're usually vascular. We could think about a serous-cystadenoma anyway. Um, MCN, mucinocystic neoplasms, are usually in the body, but that could occur. But one thing you also need to consider when you see solid masses in a female, even when they're older, are SPEN tumors. Yes, SPENs are typically teenagers or women in their 20s, 9 to 1 female to male ratio, but they can be seen in older patients. We've seen them in males and females older, including males in their 80s. So it's a tough call, but something to think about. Usually well defined, obstructs the duct. We talk about SPENs can be vascular, they can have calcification, they can be cystic, but they're often this homogeneous solid appearance. And so when I show you a 20-year-old female, you say, aha, could be a serous adenoma, could be a pseudocyst, but solid looking mass, 20-ish year old female, that's going to be a SPEN tumor, more classic. Another patient, calcified adrenal glands. That usually means, and they're not mass like, they're small. It could be infectious like TB, histoplasmosis, could be old bilateral hemorrhage. Those are possibilities. I don't see anything else in the patient's abdomen and pelvis, and this was due to prior hemorrhage. The patient was on Coumadin. When you have hemorrhage due to old trauma, it's usually unilateral, and it's not that common for the glands to shrink down like that. That's a little atypical, and I would have thought more of TB or histo in that scenario. And here's just a differential diagnosis list and things you need to think about. But again, things like neuroblastoma, metastasis, pheo, they have calcifications distributed or focal. It's not going to look like this dense calcifications with small atrophic adrenal glands. Dysphagia, cystic lesions subcarinal in location. So now you got to say it's a cyst. It's a duplication cyst. It could be a bronchogenic cyst. It could be a esophageal duplication cyst. Most commonly, right paratracheal and subcarinal, you got to be thinking about a bronchogenic cyst, which can be drained or resected, never malignant, but can be symptomatic and can keep growing over time. Another patient, chest pain. The key thing here is the left subclavian artery, which is markedly narrowed and thickened, and you can see that here as well and on the 3D images. What gives you narrowing of the left subclavian artery with wall thickening? And the patient also has thickening of the celiac and hepatic artery. So now you're saying it's vasculitis. The classic vasculitis, large vessel disease that involves the left subclavian artery, is Takayasu's aortitis, a good example. Patient with shortness of breath, patchy infiltrates, could be hemorrhage in the right patient, could be drug reaction. I like this case. It's a difficult case in the sense that it's obvious you have infiltrates, but they're ground glass. You're thinking infectious, inflammatory, hemorrhage, exposure. It's for the most part unilateral, a little bit on the left, but mainly unilateral. There's no nodes. The airways are patent, and this was active TB. So we tend to think about TB in the apices with calcification. Acute TB can have those ground glass appearances. Another patient, mediastinal widening, enlarged nodes in the paratracheal and posterior mediastinum, but the nodes are in part cystic and solid. You can see the nodes tracking in the pretracheal space, both anterior, posterior, and middle mediastinum. What gives you cystic nodes? Well, lymphoma is a possibility, but that's a possibility. Nodes that were treated, that's a possibility, but the patient had no malignancy. And now I'm showing you multiple small splenic lesions. And yes, lymphoma can involve the mediastinum and the spleen, but usually not tiny lesions like this. When you see tiny lesions like this, you think about things like TB, you think about sarcoid. So now you say nodes in the mediastinum, which are necrotic. Patient has fever, small splenic lesions. You got to be thinking about TB. A really, really great case. Okay, those were 10 cases. I hope you enjoyed them. I hope you got them right. If you want, look at them again. Just Classic cases we show in conference every Wednesday at 12 o'clock. And I'm recording this right now, so I got to go back and get ready for conference. Let me see if anybody had any comments. I don't think so. Well, at least I can't see any, but I hope everybody is doing well. And with that, have a great day, everybody.